Hi, I'm Carmen Alvarez, Associate Professor and Associate Dean for Global Engagement at the University of Pennsylvania School of Nursing. I'm also a family nurse practitioner and nurse midwife, in addition to being a researcher. And this clinical experience shapes and informs the research that I do. Endurance in health equity work is the ability to stay committed for the long haul, especially when progress is slow, barriers repeat, and the no's outnumber the yeses. At the individual level, endurance starts with a deep sense of purpose. It's that burning motivation to disrupt inequities and a real life belief that health equity is possible or is attainable. That belief is what keeps you showing up, reaching out to colleagues, building partnerships, and trying again even after setbacks, especially the funding rejections. I've seen endurance show up very clearly in my work with Latina immigrant survivors of interpersonal violence. Nearly 7 years ago, I developed a mental health program for this community. And there's not a day in clinic when I'm not reminded how strong the need still is, especially for people who prefer services in Spanish. I haven't secured large federal funding to do more testing on the program, but endurance has meant continuing anyway, finding smaller pockets of support, strengthening the model, and building evidence, albeit small pockets of evidence, so it can eventually reach more communities. Endurance also shows up in our collaboration with colleagues at the University of Puerto Rico. In our COVID-19 study with healthcare workers, burnout came through as a major theme. And the healthcare workers, that is, had very thoughtful, evidence based ideas about what would help address burnout in their settings. Part of our responsibility as researchers is to disseminate our findings, and it was in disseminating what we learned from this project that helped us identify new partners who could provide capacity building support. It's not a full solution, but it's a step forward. For larger coalitions, endurance looks like creating psychological safety, spaces where people can speak honestly, raise red flags, and propose solutions without fear, because there's rarely a single silver bullet in this work. Progress comes from multiple strategies working together over time, individual commitment, supportive teams, sharing leadership, and steady investment. Endurance is the ability to sustain that multi-pronged effort long enough for real change to take root. When I think about what makes it hard to maintain endurance in health equity work, a big part of it is that we're trying to address long-term structural problems and systems that often create constant urgency without stable support. So one challenge is the reality of disinvestment that has built up over generations. Policies like redlining did not just shape housing, they shaped access to quality schools, safe environments, healthy food options, transportation, and healthcare services. So when we talk about health equity today, we're not starting from zero. We're often trying to repair decades of accumulated disadvantage, and that's not something that changes quickly. Another challenge right now is the instability in the safety net, especially when coverage and benefits become harder to maintain because of administrative burden. When Enrollment processes change when people have to repeatedly prove eligibility or when paperwork becomes more complicated. Even eligible individuals can lose coverage like health insurance um, and experience gaps in care. And those gaps disrupt, of course, continuity of care, medication access, and mental health treatment. It creates a sense of start, stop, survival, which is exhausting for communities and for the teams serving them. We're also in a moment where misinformation and distrust can directly undermine public health and evidence based practice. When the public is receiving mixed messages, or when science is questioned in ways that erode trust, it becomes harder to protect communities. And it also creates morale distress for clinicians who are trained to follow evidence and keep people safe. And I do think it's important to name the climate many immigrant communities are living in. Heightened, indiscriminate attacks on immigrant communities and shifting rules can create fear that simply showing up for care or applying for benefits for a child who is a citizen could put a family at risk. That fear leads people to delay care, skip preventive services, or avoid systems entirely, even when they are eligible and even when needs are urgent. So, when you put all of that together, what systems, policies, and practices contribute? It's structural underinvestment. It's policies that create administrative complexity. It's lack of stable funding for programs that work. And it's workplace practices that normalize chronic understaffing, high workload, and a culture where people don't always feel psychologically safe to speak up. And that has real consequences for health outcomes. We see delayed care, interrupted treatment, worsening mental health, and higher stress burden. We see chronic conditions become harder to manage. We see inequities widen, not because people don't want care, but because the conditions for accessing and sustaining care are unsustainable. A practical way I think about maintaining endurance in health equity work is bearing witness, treating lived experience as essential data. When systems are disrupted, whether it's funding, policy shifts, or even threats to public health data, we can still act on what we hear from communities and the people we serve. Bearing witness means we don't just listen, we rigorously document those experiences and treat that testimony as operational data that guides action. My mental health program, Cuidándome, came directly from that approach. It emerged from hearing again and again how Latina immigrant women, especially those with histories of interpersonal trauma, were struggling to manage chronic conditions while carrying untreated depression and anxiety. The intervention wasn't created in a vacuum, it was built from what people told us they needed in the language and context that made care feel accessible. I saw the power of bearing witness even more vividly at the start of the COVID-19 shutdown. We were in a routine operational meeting for a hypertension disparity study in Maryland, working with nurse care managers and community health workers to support patients with uncontrolled blood pressure. On that call, a community health worker broke down crying. She heard, she shared rather, that the safety net services her family relied on had suddenly become inaccessible, and she didn't know how she was going to um, support herself and them. The paradox was stark. The very people we were relying on to reduce inequities were being crushed by them. In that moment, we realized this wasn't an isolated story, it was a signal. If our frontline workforce was reaching a breaking point in Maryland, it was likely happening elsewhere too. That realization led to a multi site study in Maryland, Puerto Rico, and Ghana focused on healthcare worker experiences during COVID. We found what we found were systemic patterns of workforce undervaluation and strain, alongside evidence informed ideas from frontline workers about what would help. That documentation mattered. Our findings were cited in task force recommendations to the G20 focused on investing in frontline healthcare workers for resilient health systems. And in Puerto Rico, dissemination of the work, as I shared earlier, helped catalyze new partnerships with nursing associations to support capacity building. So when we ask how do we overcome barriers and adapt to challenges, I come back to a few practical applications. First, we create structured ways to capture community and frontline worker experience, listening sessions, rapid qualitative check-ins, and documentation that leaders actually use to make decisions. Second, building capacity through relationships, because endurance is sustained through partnerships, not individual heroics. And third, invest in the frontline workforce, especially community health workers, because community health workers don't just connect people to care, they connect people to other resources, trust, and social support. And that's a form of infrastructure for equity. In the face of disruption, bearing witness becomes an act of resilience. Their testimony is not anecdote, it's truth, and it's a foundation strong enough to build on.
Thank you so much.
Thank you. Thank you for having me.